This is the recording for Unit 9B, which is Alterations in Mental Health and Cognition. It will be short and sweet, and it's the last recording you'll have to listen to. You aren't sick of my voice yet. Okay, let me make it full screen to make it a little bit easier on you guys and me. All right, there we go. Okay, so there are obviously lots of autism spectrum disorders, especially since the DSM-5 came out. I don't want you to memorize the different disorders. I just want you to know autism as a whole, and then we'll go over ADHD and developmental delay a little bit later, but just know autism as a whole. It is quite astounding that 1 in 68 children will be diagnosed with autism, when actually the previous professor made up her slides, it was 1 in 150. So it has increased dramatically. The cause is unknown. We have talked earlier in class about how MMR does not cause autism. And interestingly enough, 4 to 5 times, autism is 4 to 5 times more common in boys than girls. Clinical manifestations, so they usually manifest by about 2 to 3 years of age. So its social development is one of the first or the main red flags because they just are not socially developing like they should. So they have altered social interaction, delayed development. I don't necessarily want you to memorize these, but just be aware of them. They're not gonna have 2-word phrases by 24 months. So again, that 2 to 3 age recognition. You can see page 797 for manifestations. Again, I don't want you to memorize them. I think you can all recognize most likely an autistic child versus a healthy child. So diagnosis, they do have screening tests, and those are typically done at the primary care doctor or the pediatrician. It's questionnaires that they do to parents, and they start them about 2 years old, and then you have the DSM-4 or 5. Early intervention is obviously the best if you can diagnose it and pick up on it as early as possible. Treatment includes speech therapy and medications. So nursing interventions are obviously important. And it's really, this is a tough one because it's totally patient specific. You can have a range of they may not even want to be touched to they want to be hugged and loved on all the time. So it's really patient specific. So you need to know your patients. Parents are great resources if they're there. Obviously, you want to protect the nurse's safety as well as the patient's safety, and they're not going to like it because they don't understand, but hand mitts or the posy bed may need to be used. Favorite items from home can be brought in. Parental presence is encouraged, not just for the patient, but also for you guys, to help the nurses understand the patient better, and maybe the mom or dad has techniques that can help the patient. All right, so moving on to ADHD. Basically, they're hyperactive. It is more common in males. You don't need to worry about the known causes. You can read over this slide yourself. There's slow brain maturation. The cortex is commonly affected, and they don't have enough dopamine and norepinephrine. Clinical manifestations, they obviously have a decreased attention span. They have decreased impulse control, anxiety, mood swings, language issues. Sometimes these obviously don't apply to everybody, just like all of these mental disorders. It's hard to, you really cannot generalize. It is really patient specific. Diagnosis is the DSM-5 criteria. treatment you do need to know because it's important to nursing, obviously. And ADHD, again, is hard because it's like, is it ADHD or is it just that the children don't want to sit at a desk for 7 hours while they're at school and only have 30 minutes to run around? I mean, it's not something that is ingrained in us to sit for that long and pay attention. So it's hard when schools, talk to parents and tell them that they have ADHD. Main thing is these children should not be treated differently than others, especially in school. Should be allowed to do everything that any other student does. Certainly don't separate them from other students. Allow them to be as normal as possible. They also shouldn't be told they can't do something because of their diagnosis. They can do anything and everything that a child without ADHD can do. Medications, you should know the side effects. And in terms of nursing and in terms of just dealing with people with ADHD and honestly dealing with you guys half the time, you may have to repeat your teaching if you're going over like teaching before a procedure or teaching, discharge teaching. You may have to repeat it several times because they may not be able to, their attention span may not be that long, and then you may want to provide verbal and visual items for them if the children are old enough. So the side effects of the medications, they may have cardiac issues. And so, they're going to have regular blood pressure checks. They're going to probably have at least a baseline EKG done and then potentially one done later. Anorexia, they don't want to eat, so you may not or should not give the medicines before or with the meal. You may want to do it after or like way before, first thing when they wake up in the morning. And then also insomnia, so you obviously wouldn't want to give them their medications at night. So intellectual disability, they have limited intellectual function. Their IQ is less than 70 to 75. The etiology and the biological environment and stuff like that, you don't need to memorize, but I would encourage you to just read over it and be aware of it. My slides are up to date and posted on Blackboard. The clinical manifestations, again, they depend on the child and they're diagnosed with the DSM-5. Treatment is going to be a multidisciplinary approach, and then if you have a patient with an intellectual disability, and you can have an adult with an intellectual disability, or any of these, so this really applies to not just pediatrics, but this is when you first see it and first have to learn how to deal with it. So you really just need to assess your child and, what can that child understand? What can they do? And you need to tailor your teaching and interactions to that specific patient. There's obviously severe intellectual disability versus mild. You do want to think about the family in terms of if they have severe intellectual disability, they may not be able to cope as well, and so you want to provide resources. Or even mild, it kind of changes their idea of having, a perfect, successful, well child, and if they're severely delayed, they're probably going to look at potentially, lifetime care and stuff like that. So you really want to be able to support the family and address their coping issues. Hopefully they have good coping issues, but as you know, most families in nursing do not. And that's all for that slide. It's told you it would be short and sweet, so let me know if you guys have any questions. Otherwise, I'll see you on Tuesday.